colleague from University of Michigan, Christine Konopka, from our Department of Pathology. Perfect. Voila. And our session today is on COVID-19-related lung disease, histopathologic correlates. I am here just to guide the ship, I guess, and talk about the clinical cases and discuss them, and we've all been in those situations. But the stars are sitting next to me regarding the histopathologic correlations and the radiographic changes. And welcome to the session. I think this is going to be a great session. I have a lot to learn also, and we appreciate your attention today, and I again apologize for the delay. Dr. Wong is my colleague who unfortunately is not here, Dr. Smith, and Dr. Konopka. So what are our objectives today? One is to describe the pattern of COVID-19 associated ARDS. The next is to recognize the manifestations of patients who have persistent COVID-19 and may benefit from corticosteroids or antifibrotic therapy. Next is to describe and correlate imaging and histopathologic findings of acute and persistent COVID infection. And so what are the clinical manifestations? And it's going to be a bit segmented into the acute changes or ARDS type changes that we see. Then there's the post-COVID-19. As you know, there could be a lot of descriptions of organizing pneumonia, perhaps in response to acute therapy. And then the last area that we know much less about is the persistent post-COVID-19 ILD. And so we're going to start with our first case, 72-year-old former smoker admitted with shortness of breath and fever. That's obviously COVID positive. And this patient initially, the chest radiograph, you can see that they're in the emergency room with some shortness of breath, and there's a little bit of change, but over time it gets progressively worse, and the patient ends up on heated high flow at 60% and is getting worse until the patient is intubated. And I'm going to turn this now over to Dr. Smith. And then this is, oh, you have the pointer, Ann.
Hey, everybody. So ignore the barotrauma things that you're going to see here. I really want to focus on the changes in the lungs, because we have the good fortune in radiology when we're looking at CT of the lungs to have CT findings that fairly reasonably correlate with the histologic findings. Sorry, this keyboard is not working as I expect it to. So I really want, this sort of seems, it sort of seems like a non-specific appearance in the lungs, but we're going to go through some of these findings and sort of define what we're looking at specifically. And then you'll get the idea that some of these findings are actually quite specific for particular histology, which is a very important thing for us to know how to get through. This flow chart is one that is very helpful for me to understand the pathways that we see in COVID, but also in lots of other causes of acute lung injury. So this is sort of how I think about the temporal evolution of things and try to figure out where we are in this game and whether we're going towards recovery or fibrosis. Another interesting thing to think about is that in the patient who's intubated, ventilator-induced lung injury can also cause fibrosis in the end stage. So you could add this to this flow chart as a mechanism of injury. But first, we're going to talk about how COVID looks in the acute phases when the anticipated histology is diffuse alveolar damage. On CT, well, you know, chest x-ray, we saw those 3 chest x-rays, pretty nonspecific. I think it's difficult to go through chest x-rays and their findings without understanding what's happening on CT. So, so we're going to go through CT findings of diffuse alveolar damage. These are proven radiologic findings they're radiologic findings in path-proven diffuse alveolar damage, whether that be due to COVID or other. And we can organize the findings into acute and organizing phases that correlate with those same phases of the histopathologic description. So we'll go through all of these findings, acute phase and organizing phase. So in the acute phase, we really see diffuse or patchy, sometimes confluent ground glass opacity, sometimes getting more consolidative dependently. But there's not much architectural distortion. Again, so patchy and diffuse, sometimes confluent, ground glass opacity, tending towards consolidation dependently, but really no architectural distortion. So on the top here, we have these patchy areas of ground glass, some confluent ground glass, but it doesn't look like the lung architecture is distorted. This can come in sort of nodular appearances, as you see on the bottom. Here's some more confluent disease. Again, as you go dependently, it tends toward consolidation. And then, of course, this is a classic ARDS picture because it's DAD. So you could see this, again, in any cause of DAD, but this is just a perfect classic example of how that ground glass becomes more consolidative in the dependent lung. Now, on the top, we have acute phase, DAD, and on the bottom, we have an example of the organizing phase. So Christine will talk to you about what exactly is happening on a histologic level in the organizing phase. But what we see on CT correlates to that histopath. So we see architectural distortion. So you see that the normal architecture, the normal pattern of the branching of the parenchyma of the lung or the configuration of the secondary pulmonary lobule changes. You get traction bronchiectasis and traction bronchialectasis because of the fibrosis that is developing in association with the organizing phase. So I'll give you a few more images just to sort of give you the spectrum. Here you see that what was ground glass opacity is sort of melting away. We're left with a little bit of sort of reticular ground glass, but not that fulminant ground glass. And you see the arrow pointing to a big cylindrical bronchus. This is traction bronchiectasis, and out even further toward the periphery, bronchialectasis. Here's another case where you might say, well, maybe these bronchi are not so big and I'm just noticing them because of all the opacity around them. But no, these are pretty big, and look how they're sort of beaded and jerked one way and another. These are not nice and clean and tubular bronchi. Those are being pulled this way and that due to the fibrosis in the organizing fibrosis in the underlying lung. So in a best case scenario, after an acute lung injury, which manifests as diffuse alveolar damage, what you'd like to see is that acute phase merge slowly into the organizing phase, which you see at the top from left to right, and then going from left to right on the bottom. The best case scenario is that the organizing phase does its job, the lung gets reconstituted, and you end up with pretty nice looking lung. So that's the best case scenario, and that happens not infrequently after an acute lung injury.
All right. So the pathology of severe acute COVID, we already learned it's diffuse alveolar damage, but I think that retrospectively what occurred at the beginning of the pandemic is kind of this race to find out what does it look like under the microscope. So everyone wanted to be the first to do an autopsy and the first to publish their case report. And we were among the first at Michigan, thanks to CHEST. And I will tell you that those things that we learned in those initial case reports held true in subsequent larger series. And now, if I just do a search of diffuse alveolar damage and COVID, over 300 publications pop up. Of course, not all of them pathology, but we were all saying the same thing, just reinforcing those initial studies. So what did those say? As already alluded to, we know that COVID-19 causes diffuse alveolar damage, which we will learn is morphologically indistinguishable from all other causes. So DAD is the most common histologic finding in patients with ARDS. The converse is not true. About 90% of patients with DAD will have ARDS, but that doesn't hold true. Not all patients with ARDS have diffuse alveolar damage. Now, when we talk about diffuse, we're not talking about diffuse involvement of the lung, as we just learned moments ago that it can be a patchy disease. What we're talking about is diffuse injury at the level of the alveolus, injury of the epithelium, endothelium, and interstitial space. This is an old diagram, but it holds true today. Diffuse alveolar damage progresses in a stepwise fashion that's predictable from the acute to organizing phases. The early stages are characterized by edema that includes interstitial, kind of this, oh, I don't know that this, all right, the thickening of the interstitial space here at the level of the alveolus, and then edema within distal air spaces as well. Characterized by the quintessential hyaline membrane in the acute phase, that bright eosinophilic hyaline membrane there that you see pushed up against the wall of the alveolus. And then intraalveolar fibrin deposition can be variably conspicuous. Now, for me, a lot of findings, if you look at the publications about AFOP, acute fibrinous organizing pneumonia, I think some of those are probably DAD, in which the hyaline membranes are not seen, whereas others fall into category of organizing pneumonia with prominent fibrin deposition. Nonetheless, fibrin deposition is a prominent, variably conspicuous component. Organizing DAD. This is where the lung is trying to repair itself. It's characterized by architectural collapse due to the loss of surfactant. So the type 2 pneumocytes are trying to repair the epithelium there. They're proliferating. And then you have kind of this immature scar that forms. That's this fibromyxoid tissue that you see in here, this pale appearance as the lung tries to repair itself. Organizing diffuse alveolar damage is frequently characterized by the presence of fibrin thrombi and squamous metaplasia. Now, features of COVID-19 related DAD. So earlier in the COVID-19 pandemic, there were these publications, first it was single case reports and then larger series describing just COVID-19. And basically, they were describing all these features and attributing them to COVID-19 that I have listed here. Some individuals were focusing on lymphocytic infiltrates, increased megakaryocytes, and the list goes on. But really, the important point to remember is these were uncontrolled studies. These were not blinded or controlled. So we did that at the University of Michigan in our series. It was a blinded, case-controlled study in which we looked at patients who were hospitalized with COVID-19 and succumbed to disease, those that died in the community of COVID-19, and then looked at pre-pandemic individuals in both of those cohorts as well. And we found that there are no features specific to COVID-19 related DAD. I can't tell the difference under the microscope. So all those features that were listed, completely non-specific. A subsequent group looked at COVID-19 as controlled against other viral pneumonias, those who died. They found similar findings, really nothing specific. So determining the cause of DAD is completely dependent on clinical data, which you know well, and now that we have the PCR, it's super fast and it's not such a question as it was earlier in the pandemic. As already alluded to, some patients may go on to develop fibrosis, whereas many go on to resolve, and this is kind of a late resolving diffuse alveolar damage, just the hints of kind of that fibromyxoid tissue, that scar resorbing into the lung, that fibrin is beginning to disappear, and often there are increased megakaryocytes, which are sometimes just the little calling cards that are left behind. So DAD does go on to resolve, as you well know clinically.
So what happened to this gentleman? Well, obviously he had a pigtail catheter placed, he had the barotrauma, he was on a ventilator, required a tracheostomy, and after a long-term course, he was finally discharged. And he was seen later in the post-ICU clinic with mild physical limitations without cognitive dysfunction or psychiatric deficits. And his lung functions were normal. And that to me is pretty incredible after having such a long course, having expected perhaps some changes related to this chronic or subacute inflammation that resulted from the COVID infection. And so now we've covered over the acute ARDS kind of situation with acute infection from COVID-19. And this is a patient of mine that is 87. He's an elderly gentleman and former smoker, and he developed COVID-19 and was hospitalized at an outside hospital for 2 weeks. And here's his initial CT scan, and you can see it was a PECT because it has contrast in it and with the ground glass opacities in the periphery. And he was treated with corticosteroids, dexamethasone and remdesivir, and his FiO2 levels were up. He was again on heated high flow, but eventually over the 2-week period of time, he was discharged on 2 liters nasal cannula oxygen. And he was asked to see me rather quickly, approximately 2 weeks later after he was discharged for worsening dyspnea and his limiting ability to shower. So you can imagine, you know, he got this acute infection, has ground glass opacities, and this is something that all of us saw, and then he got better, and he went home on 2 liters, but at home he's getting worse, and he's an elderly gentleman, so this could be a lot of different things. His lung function, he came and saw me, and here's his chest x-ray, and it's markedly abnormal, and he has restrictive disease. As you can see, his FVC is 57%, and his diffusing capacity was 54%. When you look at that chest radiograph, you would expect it to be much lower. And he needed at least 4 liters of oxygen with exertion. Again, the radiograph is you would expect him to be much more hypoxemic. And so I'm going to turn this over now.
Sure, we're going to talk about, again, how a different histopathology evolves over time. And we all know that this isn't a disease that evolves because we all have patients who, well, I don't have any patients, but you guys do. And so this is no news to you, but we're going to revisit that slide in a little bit. I want to talk about organizing pneumonia, another histopathologic reaction to an acute lung injury, and how that can present on CT and how that can either move to fibrosis or recovery. Organizing pneumonia has been well described in the CT literature. It has a number of different morphologies that all have been biopsy proven to represent organizing pneumonia. And sort of like the DAD, where it doesn't matter what the etiology of the DAD was, it all kind of has a similar appearance on CT. It's the same for organizing pneumonia. So any cause of organizing pneumonia can present with some of these findings. And so you're going to look at some CT images and say, well, that's what we saw in COVID, and that's just because it's an organizing pneumonia. So when when nobody knew exactly what was going on, when we started to CT these patients, the thoracic radiologist said, oh, it just causes an organizing pneumonia, because we've been looking at organizing pneumonia like this for a long time. So there are many forms. There's a nodular form that can be sort of tight-ish nodules or sort of nodular consolidation like you see on the right. We can have a peribronchovascular distribution of consolidation. You see sort of some smaller regions in the image on the left, and then more diffuse and confluent organizing pneumonia in a peribronchovascular distribution on the right. This is super classic, right? Extremely classic appearance for COVID. For whatever reason, at least in the first phase and the Delta phase, we saw a lot of this morphology, this band-like peripheral distribution of ground glass and consolidation that we recognize as organizing pneumonia from times past. There are some signs that are maybe test-worthy, the atoll sign or the reverse halo sign, where you have sort of a consolidative rim and centrally ground glass opacity. This is a very interesting time-lapse almost of the development of an atoll sign, where you have on the top left sort of an acute lung injury. And then you see, as you go to the right and then down on the bottom left, you see how in the central area of acute lung injury, the organizing pneumonia, and these things when they're biopsied end up being organizing pneumonia, so I can feel confident saying that. The organizing pneumonia cleans things up in the middle, and then there's this expanding front that progresses radially, that cleans up from the center to the outside, and eventually it just melts away and you're left with nice new lung. But of course, organizing pneumonia can progress to fibrosis, as you saw in the flow chart, and that fibrosis occurs in areas where there was organizing pneumonia in a more acute phase. So what you end up seeing in some of these chronic COVID patients, the fibrosis, if you just look at the fibrosis itself, it's not very specific, but if you look at the distribution of the fibrosis, it's in the distribution of what the DAD was or the organizing pneumonia. And because some of those are rather characteristic for COVID, like that band-like distribution, we can have some idea, even without knowing a patient had COVID in the past. If I see a particular pattern of late organizing fibrosis, I can say, oh, I bet this is from COVID, not from some other cause. So now that we have gotten an idea of some of the CT appearances, now we can relate those back to the chest X-ray. And of course, the chest X-ray can be super nonspecific. You can have a diffuse lung injury with either a DAD or an organizing pneumonia pattern or both. The patchy and nodular distribution of those things can give you patchy and nodular changes on the chest X-ray, no surprise there. But here's that characteristic appearance that we all got used to looking at, where you have that peripheral band-like distribution in the mid and lower lung zones that the arrows are pointing to. And this is merely a demonstration of that band-like distribution of organizing pneumonia that we have gotten accustomed to seeing on CT.
So whereas pathologists have contributed a lot to the literature on DAD in COVID, very little on organizing pneumonia. And the reason being, really, the pathology is not the question so often when the patients present with this kind of typical clinical and radiographic presentation. They're just not really getting biopsied. I personally have probably only seen about 3 cases, and those have been in consultation. But I will tell you that organizing pneumonia, spoiler alert, doesn't look any different than any other cause of organizing pneumonia. So I, again, can't tell the difference, not very helpful. But you already knew that they had COVID. So here is a case of organizing pneumonia. This one is not COVID related, but looks similar to this. It has this fibromyxoid tissue, kind of what we saw in diffuse alveolar damage. The lung can only respond in a certain number of ways. So it kind of forms this immature scar. In this case, they're kind of within distal alveolar spaces. Importantly, no hyaline membranes. If there's ever a question from a pathologist standpoint, am I looking at diffuse alveolar damage or organizing pneumonia that can have considerable overlap at times? One thing that I will tell you that the cases of COVID-19 related organizing pneumonia did have that I noticed was a more prominent cellular bronchiolitis. Now, is that specific for COVID-19? Certainly not. We just talked about that moments ago in kind of when we were talking about the blinded series in looking at COVID-19 related DAD, that there may be a little bit more cellularity, but certainly not specific for COVID-19. One thing I would like to mention, because I have seen this more regularly, and I think that this is important, is the development of cicatricial organizing pneumonia. This is indeed a case of post-COVID wedge biopsy performed for kind of this persistent ILD that I saw. This is cicatricial organizing pneumonia. Here you have these collagenous plugs, these collagenous plugs of fibrosis situated within distal air spaces in that distribution of organizing pneumonia. So these are the patients that go on and they have persistent radiographic abnormality following organizing pneumonia. So this I'm seeing a lot more than those patients with kind of more conventional organizing pneumonia.
And so in this particular case, I'm seeing this patient, they're getting worse. What am I going to do? We searched the literature, and this came to my attention, Doctors Myhall and colleagues, and they're from Guy's Hospital in the UK, and they reviewed patients that were discharged from the hospital, and I think there were about 800 patients. And out of all of those patients, they called them after they were discharged at 4 weeks following discharge and found out who had symptoms. Interestingly enough, the majority did not have any symptoms, but the ones, I think there were about 40%, did have some symptoms. They obtained high-res CTs and pulmonary function tests, and again, the majority had normal physiology despite having symptoms. In the end, only 30 patients ended up having, because there was a group like perhaps 15 patients that had radiographic findings or in fact had greater than 20% fibrotic involvement on the CAT scan. Some also had no physiologic changes, and out of all of those patients, only 30 patients ended up having radiographic changes. And again, this is early. This is 6 weeks after discharge. And in that group of patients with changes that were consistent with findings of organizing pneumonia, they treated them with corticosteroids, 0.5 milligrams per kilo of prednisolone. It was an average about 26 milligrams per day, and it was weaned over 3 weeks. Typically, when we treat organizing pneumonia, the treatment length is much longer and perhaps a bit higher. So this was a short course of corticosteroids. And in fact, there was improvement in FVC, TLC, dyspnea, and hall walk distance in this group of patients. And so this other group, this is the Indian group, had described, well, is it different if I use high dose or low dose corticosteroids in patients with possible organizing pneumonia that's post-COVID related? And in this particular group, they randomized 65 patients, I believe, in each group that had evidence of greater than 20% HRCT abnormalities. Again, similarly, 3 to 8 weeks out from an acute COVID infection, and randomized them to prednisolone 40 milligrams per week, 30 milligrams a week, 20 for 2 weeks, and 10 milligrams for 2 weeks, and then discontinuation, versus 10 milligrams a day for 6 weeks. And there was some complete radiologic response, only in 25% in one group and 19% in the other. But it just showed that perhaps, and this was open label, so it wasn't randomized, it was only a single center, but it just created more hypotheses. What is the right dose to use post-COVID organizing pneumonia? And in this particular case, I did give him corticosteroids. I tapered it, and I will tell you that I tried to go to every other day, and then he would feel worse, and I'd have to, that's why it took longer. But there was slight improvement in lung function, as you can see, over time. And here is his radiographs, and you can see the early one when he was hospitalized, the one I had when I initially saw him, with pretty significant improvement. He still has scarring in the lungs, but there's a lot of change that occurred. So it wasn't perfect, but there definitely was a response to therapy. And so when I approach the subacute phase of post-COVID inflammatory disease, or longer phase when patients are still symptomatic and have fibrotic changes, we end up presenting, we're fortunate enough to have expertise, and we have multidisciplinary discussions. And whenever I have an interstitial lung disease patient, I present to my group. We have the histopathologist there and the radiologist present for discussion to decide how to approach these patients. And obviously clinical trials, trying to figure out the exact cause. Some of these patients, in fact, have interstitial lung disease prior to, and there's definite data that patients with interstitial lung disease had a greater risk of developing COVID-19, even when compared to cohorts, matched cohorts with developing COVID-19. So the trial of corticosteroids in patients with some radiologic features that are consistent with organizing pneumonia, I would definitely treat with corticosteroids. I don't want to lose any lung function or take the chance that anything that could be reversed in the subacute phase will be missed. And then I monitor those patients every 3 to 6 months, similar to any patient that has interstitial lung disease. Obtain 6-minute walk. I think the 6-minute walk is a great test. It's very simple, and get chest imaging when I need it, and then pulmonary rehabilitation if they're debilitated. So some of these ongoing questions, Are there a cohort of patients that could benefit from assessment and therapy for post-COVID interstitial lung disease? And I think a lot of us are asking those questions. Is there equipoise about the use and timing of corticosteroid administration, and how do they affect the natural history of COVID-19 associated ILD? I will tell you that in the early literature, I was quite surprised at the number of patients. If you think how many patients developed COVID-19, and then the early literature did not show that the percentage of patients with chronic fibrotic change in the end. In fact, in many of the studies, it was between 5 and 10%. And as the literature goes out farther, I think we're going to see more fibrotic change. Would clinical imaging findings have improved on their own without ongoing recovery or treatment? We don't know. And is there a role for the steroid-sparing agents in this group? And it's not something that it's something we're considering, but it depends on how long you're going to keep them on the corticosteroids. So we're going to move to this case 3. It's a 79-year-old former smoker with asthma, COPD overlap. He developed COVID-19, requiring a 7-day hospitalization, again, discharged on 2 liters of oxygen. And I think we saw a lot of these patients. They get better. Established care in the pulmonary clinic due to, again, persistent dyspnea with exertion after 6 months. So this is a bit longer than the last patient.
So before I show you this CT, remember that what I've described in the past as far as some fibrotic or enduring sites of disease due to COVID-19 are usually in the distribution of the acute injury. And so I've shown you where the acute injury tends to manifest, or the patterns that it tends to follow. And so as I show you this, think about, does this look like the pattern that we would have expected from an acute injury? That didn't work at all. So what do we have? Some emphysema. But then we get into even fairly apical reticulation. Was there some honeycombing in there? And as we go farther down, we see more and more very peripheral disease, not much subpleural sparing as we've seen in some of the acuter distribution, honeycombing, and then if I can just skip ahead to the bases, we're kind of into a frank UIP pattern, which isn't really the pattern of the acute distribution. So what could be going on here? Well, we've talked about how the DAD pathway and the organizing pneumonia pathway can end up in fibrosis. And I'm going to show you some of that distribution of fibrosis, but again, thinking back to the distribution of this patient we have to think, is that the only explanation? But I need to add this information before we can attack that. So on the left, we have an acute case, right? We have diffuse alveolar damage. There's probably some organizing pneumonia in there. Christine talked about how there's overlap of the histopathology. And so we would expect some overlap of the gross findings on CT. And then in B, you see, at least not in every area of disease, of acute disease, but in many of the areas of acute disease, you have architectural distortion, traction bronchiectasis and bronchiolectasis, all of that reticulation in the left lung. And so this is 3 months out, okay? But remember, it's fibrosis in the distribution where we saw disease. Here's another case looking at the acute disease, both presumed DAD and organizing pneumonia, and where is the fibrosis 6 months out? Well, it's right there. And how do we know it's fibrosis? The architectural distortion, the traction on the airways is the key. But not really seeing, the subpleural honeycombing that we would expect in a UIP pattern, say for IPF. Okay, here's a case 7 months out. Again, you can imagine how this was that peripheral band-like distribution of organizing pneumonia. because now in a peripheral band-like distribution, we have architectural distortion and traction bronchiectasis. And so what the radiology studies have shown, and I'm just showing you a couple, there are many, is we are finding that 20 to 30% of patients with imaging out to a year, in these cases, are going to have some residual fibrosis. Okay? Some of it gets better in the short term, but at least out at a year, about a quarter of patients, give or take, are going to have residual fibrosis.
So I would argue that patients that I've seen, at least in biopsy, that undergo biopsy for post-COVID ILD, a small proportion of those are fibrotic diffuse alveolar damage, and the vast majority are something else. Well, let's first look at fibrotic phase of DAD. So these studies have been kind of done on autopsy lungs and lung explants from patients known to have COVID-19-related ARDS. The pattern of fibrosis in those patients resembles nonspecific interstitial pneumonia, which shouldn't be of any surprise. In Dr. Katzenstein's original publication on NSIP, patients that were post-ARDS, so post-DAD patients, comprise some of the patients in that cohort. So again, not a surprise here from a pathology standpoint that the pathology of fibrotic DAD is fibrotic NSIP. This may be accompanied by histologic evidence of persistent acute lung injury. Here is one of the patients from one of my series. There's this diffuse expansion of the interstitium by fibrosis that's non-distorting to the lung architecture. There's no honeycomb change. It's kind of that, if you think back to that pattern of interstitial edema I showed you, if that just becomes fibrotic, that's kind of what this looks like actually. Evidence of persistent acute lung injury. Well, I mentioned to you that in organizing diffuse alveolar damage, one of the features of that is squamous metaplasia. That often is seen. It's kind of something that takes a long time to repair. It's the squamous metaplasia of the normal bronchial and the intraalveolar fibrin deposition. Excuse me. So we know what fibrotic diffuse alveolar damage looks like, and I already alluded to that I think the majority of patients don't have fibrotic diffuse alveolar damage, but I think that they have something else. So there are only 2 series that have been published on this, to my knowledge. The first was ours at the University of Michigan. These are cases that were referred for consultation. These were wedge biopsies. And the thing that they had, other than fibrotic DAD, was usual interstitial pneumonia. Half the patients had usual interstitial pneumonia. These are wedges. In a subsequent study, these were cryobiopsies, a smaller study, but again, 2/3 of their patients had something other than fibrotic DAD. These were cryobiopsies. I think one had UIP, a bunch had something else. But suffice to say, it's almost certainly something else that your patients have, unless they have a clinical course that's suggestive of COVID-19 ARDS, and in my experience, that something else is usual interstitial pneumonia. I am not proposing that UIP is a consequence of COVID-19. I think that probably that UIP existed prior to them having COVID.
In other words, these patients, and you'll notice that all these patients who are presenting are all elderly, so that they're all at risk, presumably for the possibility of having interstitial lung disease already. And so in this particular case, we're looking for pre-existing evidence of this patient having interstitial lung disease, and now I think everyone's becoming familiar with that term ILA, or interstitial lung abnormalities, since that has now been associated with worse mortality. And then you have to, if you find this, and in this, again, this patient has dyspnea, and what we're looking for, is this the result of the COVID-19, or did this patient have something else prior? And so we have to monitor for progressive fibrotic interstitial lung disease. In fact, this patient had lung function test before he became sick, and you can see that he had mild restrictive disease with an FVC of 78%, true with the total lung capacity. Diffusing capacity at that time in 2015 was normal. And now post-COVID infection, the patient has an FVC of 50%. I think this is a typo. As you can see, the FEV1 mils is the same. So it must be in the 50s, and you've got moderately severe restrictive lung disease with very severe diffusion impairment now. And so when you look at the pre-COVID CT, you can see that this patient, I don't know, you'd call that honeycombing change?
Yeah, I mean, this is the patient that we scrolled through the CT, and we saw that unexpectedly the pattern of ILD fibrosis was kind of a UIP pattern, and that was a little bit unexpected. Well, this is the pre-COVID CT, and you see that there's already reticulation, there's already honeycombing in a subpleural distribution. So this could have been called a probable UIP pattern or even a UIP pattern before COVID, and then after COVID, of course, things get much worse.
So how would you classify this CT? This is obviously post-COVID. There's been progression, and how would you classify this at an ILD conference?
Yeah, that's a UIP pattern, and you know, this could be a patient with just IPF and no history of COVID. So that is a pure UIP pattern in the classic form.
Okay. And so in this particular case, COVID can unmask pre-existing ILD in some patients, and that's something that we have to look at. And again, during my PG course review, there was I pointed out a case cohort study that's from Korea, and in Korea they have the national health insurance system that tracks all of the patients that develop COVID, and they did a case cohort match, 15-1, and including location of the patients, and there was a strong correlation that indicated the susceptibility of COVID infection was higher in patients with interstitial lung disease and worse disease severity of COVID infection. And this has been proven in several other studies too. And it makes perfect sense because the patient has underlying interstitial lung disease as far as severity of disease. So perhaps this patient had this, perhaps it was detected, they don't follow up, and whether or not this is a result of the COVID or not is sometimes unclear. But post-COVID-19 pulmonary fibrosis in itself is not well defined, and so we're still learning a lot about this, and we need more longitudinal data greater than 1 year. The other thing is that we're seeing less hospitalizations, we're seeing less biopsies, again, because of the Omicron variant, which I'm very happy about. I'm still recovering, as all of you are, although I know in the UK that there's been an increase in the number of hospitalizations and COVID infections. There are ongoing trials because the major question everyone asks is, what should I do with these patients if they're having progression? Or what is your first response when you find a patient with fibrotic lung disease and they come to present with you and they in fact are having dyspnea or developing hypoxemia? And so the question that we're raising right now, was this ILD present before they got COVID, or is this a result of the COVID infection? And I don't think that's clear. But I know that the group in Mount Sinai is looking at nintedanib in fibrotic lung disease, and there's also a study in Spain and pirfenidone, and India, pirfenidone versus nintedanib in fibrotic lung disease after COVID pneumonia. And you can see that sirolimus is being evaluated as well as other medications in the treatment of fibrotic lung disease. And that's pretty much it. We got through fairly quickly, so we're going to have time for questions. But I really like to thank the speakers. They were fantastic. I learned a lot about the histopathology and the radiographic changes. And I think that this is really exciting, and hopefully we'll have less fibrotic lung disease from COVID. But we really appreciate your attention, and we're happy to take any questions. Thank you.
Thank you. Wonderful presentations. I have two questions. One from the clinical standpoint, when you start those patients on those steroids that you were describing, on the top of their radiographic improvement, do they also improve in their 6-minute walk test, PFTs, and those type of parameters?
Yes, they do. I had one younger patient, and he got off of his oxygen and improved remarkably. This 87-year-old patient, he had underlying comorbidities and such, and did not improve as much. And I think he had, as you could see, he still had residual fibrotic changes, and so again, it could have unmasked something that he may have had underlying before, because he was a smoker too.
And the second question, and I'm sure it's kind of a small cohort, so it's probably premature to make any conclusions out of it, but in the case of incidence of those fibrotic lung changes, have you noticed any difference between vaccinated and unvaccinated population? Thank you.
That's a great question. Do you have any answers to that? Vaccinated and
unvaccinated for residual fibrosis.
I don't know. Yeah, the answer is I don't.
does anyone? I don't know any data on the. Obviously, we have been the unvaccinated, sicker patients have been problematic, obviously, and again, there was the group of greater than 50 years of age, right, that are unvaccinated do very poorly, whereas the younger, less than 50 years old group do better. But I don't have any data on whether, if histopathologically there are any other changes that occur. Yes.
That was a great session. Thank you all so much. I had a question with regard to steroids and, trying to either treat or maybe even more importantly, prevent. And it sort of came to me during your wonderful discussion about the recovery group that did the original dexamethasone study, very large study that showed the mortality benefit in people who needed oxygen or more. Do we have any data from that group or any other studies that we know of that doing steroids for the acute disease would also change the incidence of fibrotic lung disease or any ILD?
Yeah, I don't think there is, and because there's a defined. It would be nice to know what happened long term, right? In the group that they got short-term dexamethasone and then it was stopped, and I don't know the answer to that. That's a great question.
Just wondering if an ounce of prevention, if there's some change in that initial host response, obviously benefit with mortality, and so that was great, and that's why we did it. I'm just wondering if there was going to be any look at that cohort to see if there's a downstream benefit also.
Yeah, I don't know. I'd have to find out. Thank you. That's a good question.
Thanks for that wonderful session.
Sure.
I'm Tony Smith from Queens, New York, so we obviously are seeing a lot of these patients now with a longer time frame. In the patients that you described with the mild symptoms that you may or may not get prednisone, what are your thoughts about azithromycin in that group?
Well, we use azithromycin for a lot of people. It's been extrapolated. In fact, I'm a lung transplant physician, so we put everyone on 3 times a week azithro at 250 and are just extrapolating back from the CF patients, and even in the emphysema. I don't know, as an immunomodulator, there have been some studies looking at it in interstitial lung disease and such. I have not done that. And I don't know if anybody else has any other data, or do you do that, or do you have any?
During the acute hospitalization, they're getting, in addition to the dexamethasone and the remdesivir, they'll get azithromycin. So I'm just wondering, on these milder patients, would it be useful?
I haven't seen any data supporting that, and many patients get it anyway because they're being sometimes treated with for community-acquired overlying pneumonia initially, but I just don't know.
Right, well, everybody gets a Z-Pack.
Yeah. Everyone gets a Z-Pack. Thanks. Anything else? I hope it was a helpful session, and thank you very much for coming to CHEST. Please evaluate the session. Thank you for the speakers, and I hope to see you in Hawaii next year. Thanks. That was great.
That was great.
That was fantastic. You really did.